Part A. Extract 1. Questions 1 to 12. You hear a doctor talking to a patient called Mihira. You now have 30 seconds to look at the notes.
Good morning, Mihira. Please have a seat. What brings you in today?
Oh, Dr. Silverster, good morning is a rather generous description of how I'm feeling, I must say. It's been quite the ordeal, honestly. I was trying to be so proactive, really focusing on my fitness, and then thwack. Just like that.
I see. Can you tell me a bit more about what happened and what symptoms you're experiencing?
Well, yes, of course. It was about, 5 days ago now. Last Monday, to be precise. I was at my usual spinning class, the high-intensity one, mind you, because I truly believe in pushing boundaries, And I was really feeling the burn, really getting into the rhythm. And then I decided to try that new elliptical machine they just installed. It's got a much longer stride, apparently, which is supposed to be better for joint articulation. Anyway, I was on it for maybe 10 minutes, perfectly fine, and then I just felt this wrench. Not a sharp, searing pain immediately, more of a sickening lurch, if that makes sense. It felt like something in my knee just shifted. Disconcertingly so.
And what happened after that, Mihira?
Well, I immediately had to stop. I almost fell off, actually. The initial discomfort was manageable, but then the pain really started to set in. It was a deep, throbbing ache, primarily focused on the patellar region, but also radiating down into my tibia and up towards the distal femur. And the swelling. My goodness, Dr. Silverster, it looked like I had a small melon strapped to my knee. I've always been rather prone to edema, ever since that bout of acute phlebitis I had years ago, remember? Though that was on my ankle. But this was just immense. And the skin felt so taut, almost glossy.
Right. And what about your mobility? Had you been able to put any weight on it?
Absolutely not. Well, I tried, of course, because I'm not one to just give up, I tried to take a step, and my knee just buckled. It felt completely unstable, like it wasn't connected anymore. There was a distinct feeling of something being out of place. And the pain escalated dramatically with any attempt at flexion or extension. Even just lying in bed, trying to find a comfortable position, was a nightmare. I've been using 3 pillows just to prop it up. I've also noticed a peculiar clicking sensation, almost like crepitus, whenever I attempt to move it, even passively. And it feels warm to the touch. Quite erythematous, actually.
I see. And Mihira, what do you try to alleviate these symptoms at home?
Oh, everything. I've been so diligent. First, the rice protocol, naturally. Rest, plenty of it, though it's hard when you're used to such an active lifestyle. I'm usually up at 5 a.m. for a run, then yoga, then weights. You get the picture. Ice packs, constantly, for 20 minutes every hour. I set a timer. And compression bandages, though I found they exacerbated the throbbing a bit, so I loosened them. And elevation, as I mentioned, with the pillows. I also tried some arnica gel, because my holistic practitioner swears by it for contusions. And I've been taking ibuprofen, 400 milligrams every 4 hours like clockwork. It helps with the pain a little, but the swelling persists, and the instability is still very concerning. I even considered trying my grandmother's old turmeric paste recipe, but I thought it best to consult you first.
Right. Well, Mihira, it sounds like you've been thorough. Based on your description of the acute onset, the significant swelling, the instability, and the feeling of something being out of place, it's highly probable you've experienced a knee dislocation. This would explain the sudden buckling and the inability to bear weight.
Oh my goodness. So it's not just a sprain then? More profound somehow.
It's a more severe injury. We'll need to confirm this with imaging, likely an X-ray, to rule out any fractures. The immediate treatment will involve reducing the dislocation. This will alleviate the pressure and restore stability.
Oh dear. Well, I suppose it's better to know. At least now we have a plan. Thank you.
Extract 2. Questions 13 to 24. You hear an ENT specialist talking to a patient called Mihira. You now have 30 seconds to look at the notes.
Good morning, Mihira. Please take a seat. What brings you to the ENT clinic today?
Oh, Dr. Smith, it's not exactly a morning for me, you know? It's more like a perpetual tilt, a constant disequilibrium that's been plaguing me for weeks, possibly months now. I've tried to ignore it, to simply power through, but it's become, well, frankly, insufferable. It's a full-blown existential crisis of balance.
I understand, Mihira. Can you describe these sensations in more detail? When did they begin, and what exactly do you experience?
Well, the precise onset is a bit nebulous, you see. I'm quite an active person, always on the go, managing my boutique, attending art auctions, volunteering at the local animal shelter, so I'm used to a certain level of frenetic energy. But about, I'd say, 6 to 8 weeks ago, I started noticing a peculiar feeling. It wasn't spinning, not true rotational vertigo like that time I spun too many times on a fairground ride in my youth, thank goodness. No, this is more of a swaying sensation, like being on a small boat in calm waters, perpetually rocking. Sometimes it feels as if the floor is dipping beneath my feet, or the walls are subtly shifting. It's particularly pronounced when I'm in a visually complex environment, like a busy supermarket aisle, or when I'm scrolling quickly through images on my tablet. And don't even get me started on driving. The peripheral movement of other vehicles makes it almost unbearable.
Mihira, have you noticed any other associated symptoms? Any hearing changes, tinnitus, or ear fullness?
Yes. That's the other part of this dreadful symphony. My hearing, it's peculiar. It's not a complete loss, no, but it fluctuates. Some days, sounds are muffled, as if I'm listening through a thick fog. Other days, things are piercingly loud, almost hyperacusic, especially high-pitched frequencies. And the tinnitus. It's a constant, low-frequency hum, like a distant refrigerator, sometimes escalating to a high-pitched whine, almost a whistle. It's bilateral, too, though sometimes more prominent in my right ear. And yes, a sense of oral fullness, particularly on those days when the hearing is worse. It feels like my eustachian tubes are permanently blocked, even though I've tried all my usual tricks, yawning, swallowing, even that Valsalva maneuver my physiotherapist taught me for pressure equalization.
Have you tried any remedies for these symptoms, Mihira?
Of course. I'm a firm believer in proactive self-care. Initially, I thought it was just fatigue, so I increased my sleep. Didn't help. I even tried a gluten-free diet for 2 weeks because my neighbor swore her vertigo improved on it, though I'm not convinced about that link personally. Then I cut out caffeine and alcohol completely, thinking it might be a vasovagal response. Still no change. I've been religiously taking ginkgo biloba supplements for its purported benefits on cerebral blood flow and a complex B vitamin, hoping to support my neural pathways. And for the ear fullness, I've been using a saline nasal spray, imagining it might drain something, anything, from that general region. Nothing has provided any sustained relief.
I see. Given the constellation of symptoms you've described strongly suggests a diagnosis of Meniere's disease. The exacerbation by visual stimuli is also consistent with some forms of vestibular dysfunction.
Oh, I've heard of that. Isn't that what causes those dreadful spinning attacks? But I don't get the spinning.
We'll need to conduct some diagnostic tests to confirm this Mihira. We'll start with a full audiogram to assess your hearing thresholds and a tympanometry to check your middle ear function. We'll also perform a video nystagmography to evaluate your oculomotor and vestibular systems. This will help us identify any nystagmus or other abnormalities in eye movements that correspond with your balance issues.
That sounds rather involved. Will I have to wear those dark goggles? I do hope it's not too disorienting, given how I'm already feeling.
It can be a little disorienting for some patients, but it's crucial for gathering objective data on your vestibular function. Mihira, once we have the results, the treatment typically involves a multi-pronged approach. Initially, we'll focus on symptomatic relief and lifestyle modifications. This often includes a low-sodium diet, as fluid retention in the inner ear is believed to play a role in condition. We might also prescribe a diuretic to help manage the endolymphatic eye drops. For acute episodes, we can use antiemetics or vestibular suppressants to alleviate nausea and dizziness. Long-term, vestibular rehabilitation therapy is highly beneficial. This involves specific exercises designed to retrain your brain to compensate for the altered input, improving your balance and reducing the sensation of unsteadiness.
All right, Dr. Smith. It sounds like a lot, but if it means getting my equilibrium back, I suppose it's worth it. Thank you.
Part B. In this part of the test, you'll hear 6 different extracts. You'll have time to read each question before you listen.
Good morning, Dr. Carter. It's Mihira, the community nurse. I'm calling about Mr. Peterson, your patient in Block C.
Ah, Mr. Peterson. Yes, the gentleman with the persistent dermal ulceration. What's the latest, Mihira?
Well, that's precisely why I'm ringing. The venous ulcer on his medial malleolus, which we've been managing with those zinc oxide bandages, it's actually responding quite well to the compression therapy. Granulation tissue is visible minimal exudate. However, I'm rather concerned about the other lesion, the one on his left great toe. It's significantly deteriorated since my visit on Wednesday.
Deteriorated? I thought we were just observing that, given his peripheral neuropathy. Is it acutely inflamed?
Not acutely inflamed, per SE. There's no significant erythema, and the warmth is minimal. But the margins are becoming indistinct, and there's a noticeable pallor around the ulcer bed. More importantly, he's reporting a heightened level of tingling and some intermittent burning, which he hadn't articulated quite so intensely before. It's not the usual dull ache he gets with his established diabetic neuropathy. This feels different, he says. Like cold fire. He's usually quite stoic, so for him to volunteer that level of discomfort is rather telling. I'm worried it's progressing beyond a simple neuropathic concern.
I see. So, the character of the pain has altered, and the lesion itself shows signs of impaired perfusion. That's concerning. Could be a vascular component emerging. We'll need to schedule him for a Doppler study, perhaps an ABI. We need to rule out critical limb ischemia, given those new symptoms.
My thoughts entirely, Dr. Carter. The standard neuropathic pain medication isn't touching this new sensation, either.
Right. I'll arrange the referral promptly. Thanks for the heads up, Mihira.
Question 26. You hear a surgeon called Mihira talking to a GP. Now read the question.
Good afternoon, Dr. Thompson. It's Mihira, calling from surgical admissions. I'm ringing about Mrs. Davies, the 72-year-old lady you referred with the acute abdominal pain.
Ah, Mrs. Davies. Yes, I suspected appendicitis, though her presentation was a little atypical for her age. Any developments?
We've completed her workup. Her inflammatory markers were elevated, and the CT scan did show some periappendiceal fat stranding, which initially supported your differential. However, on closer examination during the laparoscopy, her appendix appeared entirely benign. No signs of inflammation or rupture.
Oh, really? That's unexpected. So, Mihira, what was the source of her acute pain then? Her tenderness was quite localized.
Exactly. That's where it got interesting. While the appendix was fine, we identified a segment of distal ileum that was markedly inflamed and thickened. It had a rather cobblestone appearance, consistent with regional enteritis. She also had some mesentery lymphadenopathy in that area. We took biopsies. It seems the acute pain was indeed localized, but the underlying pathology wasn't appendiceal. We're leaning heavily towards a new onset of Crohn's disease, rather than the expected surgical emergency. The previous intermittent bowel irregularities she'd mentioned now make more sense in this context.
Crohn's disease, you say? That certainly shifts the management paradigm. I'll need to review her history with that in mind. So, no appendectomy, then?
No appendectomy. Given the findings, conservative management for the inflammatory bowel disease is now indicated, rather than surgical intervention for presumed appendicitis. We'll wait for the histology from the biopsies to confirm, of course, but the macroscopic appearance was quite clear. She's stable and recovering well from the diagnostic procedure.
Understood. Thank you for the detailed update, Mihira.
Question 27. You hear a head nurse called Mihira conducting a staff meeting. Now read the question.
All right, everyone, settle down. Thanks for coming. Just a quick huddle this afternoon. Tom, can you give us an update on the new 4-pump calibration protocol?
Sure, Mihira. We've managed to get through most of the pumps on Ward 4, and the initial feedback on the new software interface has been largely positive from the day staff. Night shift still has a few glitches, but we're addressing those.
Good, good. Now, on to something else that's come to my attention. There have been several instances of minor equipment not being returned to the central sterile supply unit after patient discharge. I'm talking about things like personal blood pressure cuffs, pulse oximeters, and even thermometer probes. It's not just an isolated incident, it's becoming a pattern across shifts.
Oh, I've noticed that too. We're sometimes scrambling for them at admissions. Is it just forgetfulness, do you think? Or perhaps a disconnect between the discharge nurse and the patient care assistants?
That's what I'm trying to ascertain. The issue isn't really that they're being misplaced on the ward, they simply aren't making it back to CSSD for reprocessing. This leads to a shortage of readily available, sterilized items, which then impacts our turnaround times for new admissions. We're consistently having to request expedited cleaning cycles, which puts undue strain on the CSSD team. Essentially, it's creating a bottleneck. We need these items back in circulation to ensure patient care isn't compromised, and frankly, to avoid unnecessary expenditure on replacements.
I see. So Mihira, it's about the broader workflow implications.
So, from tomorrow, I want every discharge checklist to explicitly include a final equipment sweep. Let's make sure everything that leaves a patient's room makes it to where it needs to be.
Question 28. You hear a physiotherapist called Mihira talking to a GP. Now read the question.
Good morning, Dr. Chen. It's Mihira from the physiotherapy department. I'm calling about Mrs. Henderson, the patient you referred last week for her chronic lower back pain.
Ah, Mrs. Henderson. Yes, Mihira, we've tried various analgesics. How's she responding to the initial exercises?
Her lumbar extension exercises are progressing, and she's managing the core strengthening routine quite well, surprisingly. The general stiffness has slightly improved. However, the intermittent sharp pain radiating down her left leg, which was initially sporadic, has become more frequent, especially with prolonged sitting or forward flexion.
Radiating pain, you say? I was hoping the general strengthening would address the neuropathic component.
Indeed. But the nature of this particular pain seems distinct from her broader myofascial discomfort. It's a very specific, almost electrical sensation, localized to the S1 dermatome. We've even adapted her exercise program to minimize any discompression, focusing on neural glides, but it hasn't really shifted the needle on this particular symptom. In fact, her straight leg raise is now quite limited on that side, indicating increased neural tension. It's making her regular exercises almost impossible to perform effectively, and frankly, I'm concerned about exacerbating it without further investigation.
I see. So Mihira, the targeted physiotherapy isn't resolving the specific neural impingement. That's a critical piece of information. It sounds like the initial conservative approach isn't fully addressing the root cause of that specific symptom.
I felt it was crucial to inform you before we push further with aggressive rehabilitation.
Agreed. Thank you, Mihira. I'll arrange for an MRI to get a clearer picture of that nerve root.
Question 29. You hear a nursing manager called Mihira talking to a doctor. Now read the question.
Good morning, Dr. Evans. It's Mihira, the nursing manager. I'm calling about the recent rise in medication errors on Ward 2.
Goodness, Mihira. I was just reviewing the incident reports. It's certainly alarming. Is it primarily related to new admissions, or are specific drug classes involved?
It's a mix, honestly. We've seen a couple of instances with incorrect dosages of warfarin and one near miss, with an insulin error on a patient newly transferred from ICU. However, the most consistent trend we're observing isn't about particular medications or even patient acuity levels. The common denominator appears to be during shift changes, particularly the handovers from afternoon to night. There seems to be a significant dip in adherence to the two-nurse check protocol. Nurses are feeling rushed during these crucial times, and documentation often lags.
So, it's not a knowledge deficit then, but more a procedural lapse under pressure.
Exactly. They understand the protocol perfectly, but the sheer volume of tasks converging at handover, coupled with the need to quickly attend to evening rounds, means corners are being cut inadvertently. It's creating a systemic vulnerability. The new junior staff are also feeling hesitant to challenge senior nurses during these high-stress moments.
That's concerning, Mihira. We need to address that systemic pressure point.
My thoughts precisely, Dr. Evans. We need to look at how we manage that handover period more effectively.
Question 30. You hear a nurse called Mihira talking to a surgeon. Now read the question.
Good afternoon, Dr. Jenkins. It's Mihira from Post-Op Recovery. I'm calling about Mr. Harrison, the patient who had the laparoscopic cholecystectomy this morning.
Oh, Mr. Harrison. How's he doing? Any post-operative nausea?
Initially, yes, he had some mild emesis, which we've managed effectively with ondansetron. His pain control is adequate with the prescribed PCA, and he's mobilizing well. However, I've noted a persistent low-grade fever, 38.1 degrees Celsius, for the last 3 hours, despite being well hydrated. His heart rate is stable, and his wound site looks clean, no overt signs of infection there.
A persistent low-grade fever, not ideal, but sometimes seen after general anesthesia. Mihira, any respiratory symptoms? Cough, crackles?
That's what prompted my call, actually. While his chest sounds are clear on auscultation and there's no productive cough, his oxygen saturation has consistently hovered around 93% on room air, dropping to 91% with any exertion. He's also complaining of a slight, generalized discomfort in his chest, distinct from his surgical pain. This, coupled with the fever, suggests we might be dealing with something beyond just post-op atelectasis. I'm concerned about early-onset pneumonia, or perhaps a small pulmonary embolism, given his age and immobility before surgery.
Right, that subtle desaturation combined with the fever is key. We need to rule out anything serious. Mihira, I'd like a chest x-ray and full blood count immediately.
Will do, Dr. Jenkins.
Part C. Extract 1. Questions 31 to 36. You'll hear an interview with a dermatologist, Dr. Mihira.
Welcome Dr. Mihira, a leading dermatologist with extensive experience in trichology and aesthetic procedures. Dr. Mihira, thank you for being with us.
It's my pleasure, Liam. Happy to shed some light on this fascinating field.
Dr. Mihira, let's start with the basics. Many people are familiar with the term hair transplant, but could you elaborate on the fundamental principles behind the procedure? What exactly is happening at a cellular level, and what makes it a viable solution for androgenetic alopecia?
Excellent question, Liam. Fundamentally, hair transplantation relies on the principle of donor dominance. This means that hair follicles harvested from areas resistant to the effects of dihydrotestosterone, typically the occipital and temporal regions of the scalp, the donor area, retain their genetic programming when transplanted to balding areas, known as the recipient area. So, a hair follicle from the back of the head, when moved to the front, will continue to grow as if it were still at the back of the head. It's not about stimulating new hair growth where none existed. It's about redistributing existing, genetically robust hair. We meticulously extract these individual follicular units, which can contain 1 to 4 hairs, and then carefully implant them into tiny incisions in the recipient area, respecting the natural angle and density. The viability hinges on the follicular units surviving the ex vivo period and then successfully establishing a new blood supply in the recipient site.
Fascinating. So, Dr. Mihira, it's about relocation rather than regeneration. Given that, What are the primary considerations a patient should factor in when deciding if hair transplantation is right for them, beyond just having sufficient donor hair?
Indeed, relocation is the key. Beyond adequate donor density, which is paramount, several other factors are crucial. Patient expectations are incredibly important. We spend a significant amount of time managing these during the consultation. It's not a magic wand, and understanding the realistic outcomes, the density achievable, the naturalness of the hairline is vital. Then there's the stability of their hair loss. We prefer to operate on individuals whose hair loss pattern has largely stabilized, usually indicated by being on appropriate medical therapy for at least a year. Otherwise, they risk needing further procedures in the future. Their overall health, including any coagulopathies or uncontrolled systemic diseases, also plays a critical role, as does their lifestyle. For instance, individuals with very active, high-impact occupations might need a different postoperative recovery strategy. A truly successful outcome isn't just about surgical skill. It's a symphony of careful patient selection, meticulous planning, and realistic patient engagement.
That holistic approach sounds essential. Now, for many potential patients, the procedure itself and its associated discomfort are a significant concern. Dr. Mihira, can you walk us through what a typical patient experiences during and immediately after hair transplant, and what measures are taken to ensure their comfort?
Absolutely. Patient comfort is a priority. The entire procedure is performed under local anesthesia. We use various techniques to minimize discomfort during the initial infiltration, such as vibrational devices or a very slow, titrated injection. Once the anesthesia takes effect, the patient should feel no pain during the follicle extraction or implantation. They might feel some pressure or a sensation of movement, but no sharp discomfort. Many patients actually listen to music, read, or even nap during the process. Post-procedure, there will be some swelling, particularly around the forehead and eyes, which typically subsides within 3 to 5 days. Mild discomfort in the donor area is common, managed effectively with over-the-counter analgesics like paracetamol. We provide clear post-operative instructions on wound care, sleeping positions, and activity restrictions to optimize healing and minimize edema. The donor area heals quickly, often within a week to 10 days, but the recipient area takes longer to fully settle.
That's reassuring for those considering it. Dr. Mihira, in recent years, there's been an explosion of clinics offering hair transplant services, sometimes with varying standards. What are some of the key red flags or warning signs patients should look out for when choosing a clinic or practitioner to ensure they receive safe and effective treatment?
This is a crucial point, Liam, as patient safety and ethical practice are paramount. A major red flag is any clinic promising unrealistic density or guaranteed overnight results. Responsible practitioners focus on natural, gradual improvement. Another significant warning sign is a lack of transparency about the surgeon's qualifications and experience. Patients should always ensure the procedure is performed by a qualified dermatologist or plastic surgeon who specializes in hair restoration, not merely by technicians operating independently. High-pressure sales tactics, excessively low prices that seem too good to be true, and a refusal to provide detailed pre- and post-operative instructions or patient testimonials are also serious concerns. Look for clinics that emphasize personalized consultations, comprehensive preoperative assessments including scalp analysis, and a clear, documented post-operative care plan. Ethical clinics prioritize patient education and long-term follow-up.
Very important advice. Moving beyond the immediate post-operative period, Dr. Mihira, what are the typical timelines for seeing the full results of a hair transplant? And what role does ongoing medical management play in maintaining these results long-term?
It's a journey, not a sprint. Patients typically experience a phenomenon called shock loss within the first few weeks to a couple of months, where the transplanted hairs shed. This is completely normal and part of the process. New growth usually begins around 3 to 4 months post-procedure. Significant cosmetic improvement becomes apparent between 6 to 9 months, but the full, mature results usually take a full 12 to 18 months to manifest as the hair shafts thicken and fully integrate. Regarding long-term maintenance, medical management is often crucial, particularly for androgenetic alopecia. Medications like finasteride or minoxidil can help preserve the existing native hair and even stimulate some regrowth, preventing further progression of hair loss in untreated areas. Without ongoing medical therapy, the non-transplanted hair can continue to thin, potentially creating an uneven appearance over time. So, the transplant addresses the balding area, but the medication supports the surrounding native hair.
So, it's not a one-and-done solution for everyone. Finally, Dr. Mihira, considering the emotional impact of hair loss, what advice do you offer patients to manage their expectations and psychological well-being throughout this entire process, from initial consultation to seeing the final results?
The psychological aspect is immense, Liam. Hair loss can deeply affect self-esteem and confidence. My primary advice is to approach this journey with patience and realistic expectations. Understand that transformation is gradual. We encourage patients to view their progress photos regularly, as it's easy to forget how much has changed day to day. Open communication with the clinic team is also vital. Any concerns, no matter how small, should be voiced. Connecting with online communities or support groups can also be beneficial, allowing patients to share experiences and learn from others who have gone through the same process. Ultimately, while the physical transformation is significant, embracing the process and focusing on the overall improvement in confidence, rather than obsessing over minute details, leads to the most profound psychological benefits. It's about feeling better, not just looking different.
Dr. Mihira, a truly insightful discussion. Thank you for clarifying so much about hair transplantation today.
My pleasure, Liam.
Now look at Extract 2. Questions 37 to 42. You hear a community nurse talking about documentation efficiency at the Mihira Research Institute.
Good morning, everyone. Thank you for joining me today. My name is Riya, and I'm a community nurse here at the esteemed Mihira Research Institute. Our topic for today is a crucial, yet often underestimated, pillar of healthcare: documentation efficiency. While it might sound like a purely administrative task, I want to emphasize that accurate and timely documentation forms the bedrock of patient safety and quality care delivery across all departments of Mihira care. Firstly, let's address the fundamental importance. Why do we dedicate so much time and training to this seemingly mundane activity? Beyond the obvious legal and ethical obligations that mandate comprehensive record-keeping, documentation serves as the continuous narrative of a patient's health journey. It's the primary means of communication among the multidisciplinary team, ensuring continuity of care, facilitating informed decision-making, and tracking patient progress or regression. For us at Mihira Care, it's not just about ticking boxes. It's about constructing a reliable, real-time clinical picture that allows for seamless transitions between care providers, whether it's a shift change, a referral to a specialist, or even emergency intervention. Without this clear narrative, gaps emerge, leading to potential errors and compromised patient outcomes. Now, how do we scientifically rate documentation? It's not as simple as counting entries. We look at several metrics. Firstly, completeness. Are all required fields populated with relevant information? Secondly, accuracy. Does the documentation reflect the true clinical picture without discrepancies or biases? Thirdly, timeliness. Is the information entered contemporaneously with the event, or as close to it as possible, to maintain its validity? Lastly, and perhaps most critically for the Mihira Research Institute's ethos, we evaluate its utility for research and audit. Can we extract meaningful, de-identified data to improve protocols, identify trends, and contribute to evidence-based practice? A robust documentation system at Mihira Care allows us to retrospectively analyze interventions, their efficacy, and any adverse events, turning raw clinical data into actionable insights for future care. Reiterating the importance of documentation, beyond its research utility, it acts as a safeguard. Consider a scenario where a patient experiences an unexpected adverse reaction to a medication. Comprehensive documentation of their baseline health, allergies, drug administration details, and subsequent response provides an invaluable audit trail. This forensic capability protects both the patient by allowing rapid identification of issues and the clinician by demonstrating adherence to standards of care. It's our first line of defense against litigation and our clearest demonstration of accountability. Furthermore, effective documentation underpins efficient billing and resource allocation, ensuring that Mihira care remains fiscally sustainable, allowing us to continue providing top-tier patient services. So, what are the key factors that contribute to truly effective documentation? It boils down to a few core principles. Clarity is paramount. Using concise, unambiguous language, avoiding jargon where plain terms suffice. Objectivity. Documenting observed facts and patient statements, not interpretations or assumptions. Regularity. Consistent entries, especially for dynamic conditions or following significant interventions. Legibility, of course, though less of an issue with our electronic health records now, but still relevant for handwritten notes in specific contexts. And perhaps most critically, relevance. Ensuring that every piece of information recorded contributes directly to the patient's care, avoiding superfluous or redundant entries that can obscure vital details. This focus on relevant data allows our team at Mihira Care to quickly extract the most pertinent information. Reiterating the importance of documentation, beyond its research utility, it acts as a safeguard. Consider a scenario where a patient experiences an unexpected adverse reaction to a medication. Comprehensive documentation of their baseline health, allergies, drug administration details, and subsequent response provides an invaluable audit trail. This forensic capability protects both the patient by allowing rapid identification of issues and the clinician by demonstrating adherence to standards of care. It's our first line of defense against litigation and our clearest demonstration of accountability. Furthermore, effective documentation underpins efficient billing and resource allocation, ensuring that Mihira care remains fiscally sustainable, allowing us to continue providing top-tier patient services. So, what are the key factors that contribute to truly effective documentation? It boils down to a few core principles. Clarity is paramount. Using concise, unambiguous language, avoiding jargon where plain terms suffice. Objectivity. Documenting observed facts and patient statements, not interpretations or assumptions. Regularity. Consistent entries, especially for dynamic conditions or following significant interventions. Legibility, of course, though less of an issue with our electronic health records now, but still relevant for handwritten notes in specific contexts. And perhaps most critically, relevance. Ensuring that every piece of information recorded contributes directly to the patient's care, avoiding superfluous or redundant entries that can obscure vital details. This focus on relevant data allows our team at Mihira Care to quickly extract the most pertinent information.